we have used this panel time to get together to talk about issues in the care of breast cancer patients. It's a complicated topic, and although there are guidelines and standards of care, there's all kinds of different ways of looking at the same information. So I think what I'd like to do is to start by asking our panel, a patient with ductal carcinoma in situ, just, some cribiform, perhaps, undergoes partial mastectomy, radiation, and then is referred to you for assessment of what's next, in terms of follow-up, tamoxifen therapy or not, and so leaving the question open-ended, I do want to address the issue of, is it mandatory that we ask our pathologists to do hormone sensitivity testing on the DCIS, with the idea that we would use that in terms of making a judgment about tamoxifen use.
Is it on? There we go. So at our institution, we actually do routinely check ER and PR, Bob, and we do that because of the B24 trial, which was the randomized trial of tamoxifen versus placebo, and which was subjected to a retrospective analysis going back and looking at ER and PR in those specimens. It suggests that the benefit of tamoxifen is pretty clear in women who had positive receptors. It suggests that there's not benefit for women who had negative receptors, although the number was very small and the statistical power is therefore pretty small. So some might argue that, it's not a trial that has very powerful evidence. I guess the other place I'm coming from is I don't know of a place in breast cancer where endocrine therapy responsiveness hasn't been pretty tightly correlated with estrogen and progesterone receptor status. I don't know why DCIS would be any different. So we do test it and we do listen to it.
So I'll jump in and say, I think here, in my opinion, this is more like chemo prevention than it is treating real breast cancer.
Oh, yeah.
And because you're probably just as much preventing the contralateral breast from having an event than you are in a radiated ipsilateral breast. However, having said that, I agree absolutely with Nancy, and one reason I do is that at the overview 3 weeks ago, what we saw was, I thought, fairly strong data that if you had an ER negative breast cancer the first time, you're pretty likely to have an ER negative breast cancer in the other breast, not absolutely. And so, again, the issue here is not whether you should use it to select tamoxifen, in my opinion, it's whether you should use it to withhold tamoxifen. And, I believe what you're doing if you treat ER negative, even DCIS patients, is you're exposing patients who are very unlikely to benefit in either their ipsilateral or their contralateral breast with a drug that has, modest cost and modest side effects.
Is there any role, acknowledging the fact that aromatase inhibitors are not FDA approved for prevention, are there ever cases where you would, on a clinical basis, use AIs in the same setting with hormone-positive DCIS?
So I'll take that first. I see what the issue says. I would argue to be very careful about using AIs in this setting, recalling that these patients are very likely to be cured no matter what you do. And I will echo Nancy's concerns in her talk. We don't know what happens when you give somebody an AI for 5 years and then they live for another 5 or 10 years. And it's not like you're taking estrogen levels from here to here. You're taking estrogen levels from here to here. And I believe it's quite possible we may see long-term toxicities with these drugs that we don't imagine right now. And in patients with DCIS, in the absence of good data to support that, I would be quite reluctant to do it. Never. I suppose an occasional patient who develops DCIS while taking tamoxifen, suggesting that tamoxifen wasn't effective, and who is rendered disease-free and would like to take that chance after a long discussion, I think would be appropriate.
I don't have any different opinion. I'm a really, really evidence-based person, and we have no evidence on aromatase inhibitors in ductal carcinoma in situ, nor do we have them in prevention. So I think the default mode is not to use those drugs in those particular settings. Remember these women do extremely well, as Dan said. I think a corollary, Bob, which maybe you were headed towards, is I am frequently asked about using raloxifene or Evista in these women. And the answer to that for DCIS, in my personal view, would also be no, 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 no. Again, we don't have a single shred of information about that particular drug in the setting of DCIS. The only drug where we have a lot of data is tamoxifen. And so that's the drug you should be employing if you think that you want to use some kind of endocrine therapy.
Okay. Let me ask another one or two questions and then open it up for others. Patient with T2 and with 8 lymph nodes positive, and was appropriately treated with surgery followed by chemotherapy, did receive radiation, took tamoxifen for 5 years, is now postmenopausal and has been on Femara, took tamoxifen for 3 years and then it was discontinued because of toxicity, depression and so forth. Was on Femara for 5 years. And so the question that I'm getting at is that in someone at high risk for recurrence, how long do people stay on an AI? And do we know that? Do we know that answer to that question?
So you've seen Nancy and me both plead for participation in randomized trials, and boy, if there was ever if we ever needed randomized data, this is the place. And so in those patients who were on MA17, which is of course the study that established using letrozole after 5 years of tamoxifen, patients who got to 5 years were randomly assigned to stopping or continuing even further. I heard this weekend that those patients who would have been eligible for that randomization, 95% or so, have reached the point. And so, and it's something like 60% of the patients who could have been randomized were randomized or something like that. So it's going to be way underpowered. And we're hoping that we will be permitted one way or another to continue to address this question by allowing women who have been on an aromatase inhibitor of some sort for 5 years to be randomly assigned to continuing or stopping at 5 years. That amendment or new protocol we hope will be around in the next few months. But if you have an opportunity to participate in that, please don't assume you already know the answer, because I don't believe you do. And either one of those could be a home run, and either one of those could be fraught with lots of difficulties. So right now, I would stop at 5 years.
Okay. Dr. Hahn, just to ask you, where are we now with limited radiation, mammocyte type, after invasive breast cancer? Partial mastectomy, node negative, very discrete mass that's resected and in past and present would otherwise be treated with standard whole breast radiation with a boost.
I think you can summarize the data, certainly that led to FDA approval for Mammocyte, as being prospective but limited in number. And so we certainly have chosen, and I don't know what your institutions have done, to use partial breast irradiation on protocol only. That being said, there are certainly indications that you can use in terms of size and location, distance from the surface, to choose partial breast irradiation. My guess is, looking at the sort of non-randomized but prospective data, that we'll be able to select a population where this is a reasonable treatment option. But that being said, until the randomized trials are complete, I don't think that we'll be able to definitively say this. And it should be noted that for some of these partial breast irradiation techniques, especially Mammocyte, that up to 40% of those patients, even when you decide you're going to do Mammocyte, are not eligible for it because of technical aspects, including distance to the skin.
Okay.
Steve, I also heard that in plastic endocytic fashion, that study is almost finished. And so that's great news.
Absolutely.
Okay. Question over here.
Yeah, are there any studies that support the how we switch from one aromatase inhibitor to another when a patient progresses on metastatic breast cancer? Is there any studies that support that?
So I think the question is, are there data that a patient who has progressed on one aromatase inhibitor, would she respond to another? And in fact, there are some phase 2 studies out of Great Britain that suggest just that. Part of this depends on what you call respond, because they frequently use both classic response and also disease stability, or so-called clinical benefit. And most common was switching from a triazole to exemestane. And one could imagine where a patient for whom the triazole might not bind to the aromatase as well as the steroid might respond to one and not the other. One might also think that perhaps there's some patients who metabolize the triazole differently when they do a steroid, might respond to one as the other. But there aren't a whole lot of data, and I would argue that with the presence of fulvestrant, I usually don't switch from one AI to another on progression. I switch from an AI to fulvestrant on progression.
So I do both. Sometimes I do switch to the other AI. If somebody has really indolent disease, you don't think you're in a big hurry, you're not completely sure that she was progressing in the first place, I'll switch to exemestane as a possibility.
You should
I
be
also-
circulating tumor cells.
No way. I'm not doing circulating tumor cells. Only as part of your trial, Dan. Having said that, I also use fulvestrant in that setting. And then the other research thing that I want to put out for you, which we should keep an eye on, is there is a literature about coming back with these women with this aromatase treatment where they've been estrogen deprived, that if you come back with a teeny bit of estrogen, that actually can be a pretty effective palliative agent. So I bet that in the future you're going to see trials that bring back estrogen, which is a drug that we all thought that we left behind decades ago.
Okay, question here?
Two questions. One, axillary node dissection versus radiation for micrometastatic disease in the axilla. And two, hormonal therapy for male breast cancer. What should we be doing?
Hormonal therapy for male breast?
So do you mean IHC positive lymph nodes or H&E stain positive micrometastases?
What? Pardon me?
Are you referring to IHC,
Correct,
immunohistochemistry
yes,
positive,
yes.
or H&E,
Immunohistochemistry.
cytokeratin positive or H&E positive?
I guess either one. I mean, I had thought of IHC, but I mean, it could be.
So I think the discussion should start off with the notion that there are no prospective randomized data to suggest that treatment of the lymph nodes with radiation or frankly with surgery leads to a survival benefit. That being said, one of the indications for axillary nodal treatment is an undissected axilla. And frequently we see this in the setting of someone who's received neoadjuvant therapy without any assessment of the axilla up front. Usually in the micrometastatic disease setting, because the risks are relatively low of axillary recurrence, it's often omitted from the radiation therapy, but I think it should be individualized. In an undissected axilla, I think it needs to be balanced with respect to the issue of toxicity. And in an undissected axilla, the risk of complications, specifically lymphedema, are relatively low. That risk goes up, of course, when you combine it with level 1, 2, and certainly with level 3 dissections.
Okay. Question?
How do you define postmenopausal status under patient age 50 based on estradiol and FSH level? In younger patient under than 50, how do you define postmenopausal status to decide about hormonal treatment, whether tamoxifen or Femara or Arimidex?
Of course, the easiest is she had her ovaries out. That would be pretty straightforward, but we're not usually quite that lucky. I think that, you know, like Dan, I have been very affected by this case report of Ian Smith's, where he talked about these women who had been amenorrheic for a very long period of time and who ended up having recovery of menses and ended up pregnant, as you heard, when they began an aromatase inhibitor. So in somebody who has been made postmenopausal by her chemotherapy, I personally use tamoxifen. I do not use aromatase inhibitors. I use tamoxifen for a few years. We just sort of see how things are going, and we'll sort it out a little later. But I would not take a 45-year-old, give her chemotherapy, and rely on those hormone levels to tell you that she's postmenopausal and can be safely treated with an AI. I think that's a kind of rocky area right now. I also did do a trial. I was involved in a trial in the United States where we looked at serial hormone levels.
What do you say?
And maybe the assays have improved, but I can tell you that
I haven't
measurement
speak yet.
was really all over the map. And so what you think you're getting back from your lab, you know, they're measuring it for different reasons. They're measuring it to help people with fertility and things like that. And so it may or may not help us with breast cancer management.
Okay.
Yes, understanding that DCIS has not been formally addressed here for the boards, what should I take for the board in summary? What should I know in order to answer those questions correctly.
Because DCIS has not been.
Call your surgeon. I think that'll be option D, call the radiation oncologist. Actually, I would argue that on the boards, I mean, I don't know what the boards are going to say, I don't write them, but I think what Nancy and I were mumbling is that A, the use of tamoxifen is appropriate. It decreases breast cancer events. Can't hear? It decreases breast cancer events, both in the ipsilateral breast and the contralateral breast. There's very little evidence that improves survival in that setting. In fact, I don't know of any, do you? And that I think it is quite reasonable to use estrogen receptor staining of the in situ cancer to select patients that you would not strongly recommend tamoxifen to.
Okay, question?
Yes.
I would guess that there might be some basic things like
Sorry.
you probably shouldn't have positive margins, you know, for the DCIS, that the local therapy is going to be important there.
Right, so I mean, I think it's very similar to invasive cancer with respect to the issue of local therapy. That is, in the absence of a simple mastectomy, right, for DCIS, that's a reasonable alternative, but in the U.S. today, that's a pretty uncommon alternative. So lumpectomy with negative margins followed by radiation. The issue of a boost versus not a boost for DCIS or even partial breast irradiation hasn't been resolved. So whole breast radiotherapy plus or minus to boost in the setting of negative margins. There is an increase.